A very good evening and a warm welcome to one and all present here. In this auspicious evening, I'd like to take a moment to introduce Planet with all of you. Planet is India's largest live digital CME and doctors generated medical content platform. You can always find us on Google, which is www.planet.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, that is medical Wikipedia for doctors. That also you can read. And in your leisure time, you can play polls and quiz also on our platform. So now, without further delay, I would like to welcome Dr. Muralidhar Kanchi, who is Dean National of ICA, to start with our today's program. Over to you, sir.
Thank you, Debalina, for this wonderful opportunity. My dear colleagues, friends, ladies and gentlemen, welcome to the second anniversary of ICA webinars. I am greatly delighted and honored to host this event on the behalf of Indian College of Anesthesiologists. Indian College of Anesthesiologists was conceived in late 90s but became a reality in 2008 when it was registered as a educational trust. It has grown since then, and the weekly webinars it conducts on Wednesdays have become very popular and a unique feature of Indian College of Anesthesiologists. Incidentally, today is an auspicious day, as Debalina pointed out, because it happens to be Guru Purnima in Indian calendar, where we do adore, respect, and worship our teachers. Today, we are celebrating the second anniversary of Indian College of Anesthesiology webinars. In fact, today it will be 104th webinar. I am grateful to all the participants and the dignitaries who have consented to be present today. And I would request Dr. Kumar Belani, Professor of Medicine and Pediatrics, Department of Anesthesiology, University of Minnesota, Minneapolis, to give the opening remarks. Dr. Belani really does not need any introduction to Indian fraternity. He is well known. And Dr. Kumar Belani, I request you to open the sessions. Thank you so much.
Good evening to all of you, and it's actually morning in Minnesota, and so welcome. I really thank everybody, especially the leadership of the Indian College of Anesthesiologists, for making significant progress over the last 3 years and for doing 104 webinars regularly, despite all the chaos in the world that was there from COVID, as well as from the war with Ukraine and Russia, and the other issues related to people behavior throughout the world. But the webinars went on and academic progress continued with the Indian College of Anesthesiologists. And I'm so glad that on this auspicious day, when we respect our teachers, the Guru Purnima Day, we are having the second annual day special virtual event today. And I welcome the leadership. I welcome the world leaders, especially Dr. Randall Clark, President of the American Society of Anesthesiologists. As you all know, the ICA has a significant collaboration and an increasing partnership with the American Society of Anesthesiologists. And I think it'll be a great idea to put all these webinars together and release it as a CD at the next ASA meeting with the president, if possible. I also welcome the immediate past president of the American Association of Physicians of Indian Origin, Dr. Anupama Gotimukala, who will say a few words, and the current president, Dr. Ravi Kohli, who is online with us, will say a few words. So again, thank you. The Indian College has made great progress. We continue to look forward to our partnerships, and I'm so happy to serve as the honorary dean of this college and wish this event today a great success. Thank you, Dr. Kanchi.
Thank you, Dr. Belani. That was a great idea that we should collate all the webinars and then make it a teaching resource material. And we will certainly look into that. And now I would like to request Dr. Radhakrishnan, the president of Indian College of Anesthesiologists, the virtual backbone of Indian College of Anesthesiologists. And he has been a visionary who has been propagating the idea of equity in anesthesia training all over the nation. So I request Dr. Radhakrishnan to come up and give the welcome address. Professor Radhakrishnan, please.
Good morning. Good evening. Hello and welcome you all to the second annual of our academic sessions, or say our academic voice in the future. The Indian College of Anesthesiologists was formed in 2008 as an offshoot of our mother society of anesthesiologists in India. And we are progressing in the said direction to bring in uniform anesthesia education and equity in anesthesia delivery all over India. And I am proud to declare we are achieving our target vision with everybody's undaring support. The college started regular academic online event on Wednesdays from mid-July 2020. And as our dean was briefing you all, this is our 104th webinar. I mean, we are able to present uninterrupted academic activities for the last 2 years, and we will continue to do so for the coming years too. College was able to make in the last 2 years, all aware of international developments as well as the international practice style building up. The lessons we learned in the past 2 years makes us feel that we need more image-oriented training, and we are determined to go ahead in that direction. We are focusing on communication strategies and capabilities, quality and safety in everyday practice, updating of skills, implementation of protocols, and data security. These are the areas where we may focus in the next 2-3 years' time. Further to that, we are establishing modular teaching and training combined with a simulated skill training and structured examination pattern. I hope with your support, we may be able to achieve all our aims. India needs more number of anesthesiology practitioners to come to some sort of equivalency compared to the developed world. And we are optimistic that India will achieve. And with that, I thank American Society of Anesthesiologists, Society for Ambulatory Anesthesia in US, and Indian Society of Anesthesiologists in helping us and giving you the needed support. Once again, the colleague, thank you all for being with us and supporting us in our vengeance. Jai ICA. Thank you.
Thank you, Dr. Radhakrishnan. That was wonderful talk. You stressed upon the importance of quality and safety and implementation of protocols and use of modular training programs for the upliftment of our fraternity here. Thank you very much. And we value your opinion. And next, I would like to invite Dr. Venkatagiri, who is the anesthesia consultant at Government General Hospital, Kesargod. He is the National President of Indian Society of Anesthesiologists. He is the National President of Indian Society of Anesthesiologists. May I request Dr. Venkatagiri to say something about the progress made in India in terms of anesthesia delivery services. Dr. Venkatagiri, please.
President ICA, Dr. B. Radhakrishnan, CEOs, Deans, faculties, fellow anesthesiologists, friends, Namaste. While I congratulate the ICA for completing 2 years of weekly webinar for various topics by renowned faculties both from within India and outside India, I wish to review the anesthesiology progress made in the last 3 decades. As I recollect my early days in anesthesia, I did my MD during 1990 to 1993. What infrastructure we had then? We had only Boyle F, red rubber endotracheal tubes, 22 gauge steel spinal needles. Both were re-sterilized and reused multiple times. And many a times doing spinal, we used to get a muscle biopsy also. No much sophistication and sophisticated monitoring facilities were available during. After all, if we had ECG monitors and very occasionally the pulse oximeter. But now we have multiple monitors. Our monitors were eternal vigilant at that time. But now we have multiple monitors from multi-para, 5-para, or even more, including the cerebral function monitors or the BIS monitors, even in smaller hospitals like a taluk level general hospital in government sector. We had only halothane, which was used occasionally, and ether was easily available. But now they are not seen in many places. We had only Goldman vaporizers. But when it was broken, it was very difficult to get Goldman vaporizers. Many times we were putting glass bottles. We say that put a Horlicks bottle and put the drug into that and use that halothane into that or ether into that and used in place of the vaporizers. Now we have Tech 7 vaporizers or even higher to that. We had no much specialties that time. Everybody was doing every case. Occasionally there was cardiac anesthetist. Now we have an array of specialists and we have DM in neuroanesthesia, DM in cardiac anesthesia, and of late now pediatric anesthesia. Then we have DM in onco-anesthesia and obstetric anesthesia. We have both specialties of specialties now, and we have a lot of opportunities after doing this thing. We see that endotracheal tubes, yes, we have come out from red rubber PVC tubes to PVC endotracheal tubes, preformed and reinforced tubes, all are disposable, and disposable anesthesia kit, HME filters, and advanced workstations and tech vaporizers with fine calibrations, 5 needles, 27 or 29 gauge, which are now used in almost every operation theatre. Patient is giving very safe anesthesia. The COVID pandemic has again liberalized the use of gadgets and made availability of these widespread. Now we have ECG monitors, pulse oximeters, cardiac monitors, ETCO2 monitors, agent monitors, MAC monitors, BIS monitors, and real-time monitoring of pulse his arterial BP through arterial lines. Again, we have extended our services outside the operating room. We give both in CT scan or MRI scan room, and we give anesthesia in remote locations like endoscopies or ECTs in remote locations. We have extended our service other than anesthesia to critical care, palliative care, and pain services. There are PGs after MD. There are multiple opportunities for the PGs, either PDCC or DM in different specialties I told earlier. Cardiac anesthesia or neuro anesthesia from earlier, and now anesthesia for the even transplant anesthesia, then neuro anesthesia, then we have other subspecialty like onco, obstetric or pediatric anesthesia, maybe sub or super specialties in anesthesia. We have changed a lot from that time. Progress made in anesthesia in the last 30 years is very significant. It is magnificent to know that we have evolved tremendously over the last few years, and we are providing very high standard, safe anesthesia services. I am proud to say that even in government hospitals, we have advanced anesthesia workstations and monitors with BIS monitors and all. To summarize, together in the last 30 years, we have seen an array of changes from primitive anesthesia to most advanced safe anesthesia. But whatever is said, that our eternal vigilance is the most important. We always had hand on pulse when we are anesthetizing, and we used to feel the patient's breath and pulse through the back, which we don't see now. That again, everyone should practice. Whether you have an advanced monitor or not, that may fail, but our eternal vigilance should not fail, and we should always be with the patient. With this, I conclude. Thank you, ICA, for inviting me for this thing, and I wish you all the best. Hope to see many more webinars for PG's consultants as well. Thank you once again.
Thank you, Dr. Venkatagiri. That was excellent sum up of anesthesia progress made in India. There has been significant advancements. Ether and halothane have been replaced with safer agents, sevoflurane and isoflurane. And the specialty has diversified into cardiac, neuro, onco, etc., as you highlighted. Thank you very much for joining us, and request you to stay back till the end. Next, I would like to take delight and pleasure in inviting Dr. Randall M. Clark, who is the professor of anesthesiology at the University of Colorado School of Medicine and is a pediatric cardiac anesthesiologist at the Children's Hospital, Colorado. He is the Honorable President of American Society of Anesthesiologists, which is the USA's largest organization of physicians anesthesiologists. Dr. Clark has served in the ASA in various roles, which includes his role as Executive Committee and Chair of the ASA sections on clinical care and professional standards. We are extremely delighted and happy that you could join us, and I would request you to tell us about the future role of anesthesiologists in clinical medicine from your viewpoint of view. Dr. Randall M. Clark, thank you so much.
It is my pleasure to join with you this morning. And good evening and good morning from Children's Hospital in Denver. I apologize that I'm in scrubs, but I'm going to the cath lab in just a few minutes. So I wanted to be able to spend as much time with all of you as possible. And for some reason, my slides are not advancing. There we go. I want to thank the leadership of ICA for inviting me to join with you today. If there's one thing that I've learned during my year as ASA president, is that we are truly a global specialty. The challenges that we face are significant, and they are frequently shared across all of our countries. So I look forward during the remainder of my year as president and in the future to increasing the level of coordination and cooperation we have between our national societies. I think it's the right thing to do for patients, and it will help us better position ourselves for the challenges in the future. So I'm going to talk a little bit about some of those challenges. I'm going to talk about those things that we have historically done in science and education. But I'm going to talk a little bit about the new challenges that we're facing, especially in the United States. Those challenges come into two areas. One is the dramatically increasing consolidation in practice models in the United States. And the second is the threat, the challenge to the economics of practice through governmental payment, and then most recently through private payment, and what our response to that is. We are seeing consolidation from very small traditional practices into medium to large regional practices, and now national corporate practices with many thousands of anesthesiologists. At the same time, those of us in academic medicine, such as myself, are seeing academic programs expand regionally in a dramatic fashion. And the challenge there, of course, is that as those academic practices expand, sometimes they lose some of the focus related to education, research, and service that's the hallmark of academic practices. We have private equity. Private equity are the private funding mechanisms where practices are acquired by private companies and then managed separately from public companies that may operate hospitals and health insurance systems. We are seeing mergers, as I talked about, and most recently, there's been an increased focus on hospital acquisition of practices where the direct employment of anesthesiologists may be by the hospital itself. So what are the implications of all this? We are trying to position our members to be able to respond to a very dynamic environment by improving our leadership materials, our leadership development programs for all anesthesiologists. This information is described on our ASA website, but we are really focusing on the full breadth of the career of the anesthesiologist, because we believe that every anesthesiologist has something to contribute to their group, department, hospital, and community through improved leadership skills. In terms of the economics of practice, we are really focusing on demonstrating the value we bring to the care of our patients. We've done this through a number of ways. I think most of you are probably familiar with our perioperative surgical home model that has been in existence for more than 10 years. We're continuing to advocate for that model and expanding it into all of the enhanced recovery systems that currently exist. We're currently studying creating an entirely new center for perioperative medicine within ASA to be able to promote these concepts of comprehensive care of the patient from the time surgery is determined to be needed until the patient has recovered, returned to work or to their school positions. And as I said, we're going to continue to do those things that we have always done well, namely science and education. The education portfolio at ASA is substantial. I would encourage you to take a look at what we offer in terms of specific scientific programs in multiple specialties, and then broad topics that serve the needs of every anesthesiologist. The journal Anesthesiology continues to be one of the leading journals in scientific publication. Our readership continues to expand. The impact factor of the journal continues to grow, and it continues to receive a high score in terms of member satisfaction among the ASA members. And I would like to just mention the anesthesiology annual meeting. It is a tremendous opportunity for both the US anesthesiologists and the international community to gather together in just a wonderful venue. New Orleans is a unique American city. I'm very hopeful that as many of you as possible can join with us in New Orleans later in October of this year. I think it's going to be the best annual meeting that ASA has ever had. And it's just a wonderful place to visit. So please consider joining us in Louisiana. So again, thank you very much for the opportunity to address you. We're going to continue to foster science and education in our specialty. At the same time, we're going to continue to give our members the tools they need to be able to respond to some of the challenges we're seeing in the US marketplace. Thank you very much, and be happy to take any questions if you have the facilities for doing so.
Thank you, Dr. Clark. It's a wonderful address by you. And I really appreciate that you mentioned that anesthesia is a global specialty, and the implications of changes that are taking place mean that anesthesiologists can serve as leaders. Thank you for that wonderful expression, and we are grateful to you for joining us this afternoon in this celebration of the second anniversary of ICA webinars. If anybody would like to ask any questions to Dr. Clark, because he's going to go to the CT scan room now, feel free.
Just wanted to mention,
yes.
we are glad that Dr. Clark has been our president, because he has certainly emphasized patient safety during the year and also promoted physician anesthesia, which is something that we all need to push as much as possible globally. And so I wanted to thank Dr. Clark for doing that.
Thank you. Thank you for that. Thank you so much. We appreciate this. Anybody would like to say something? If there are no questions, I'll proceed with the program. And thank you, Dr. Clark, for joining us. And we would like to see you and participate in the ASA at New Orleans this October. Thank you very much.
Thank you. It's a pleasure to be with you.
Thank you so much. Thank you so much. Next, it's my duty to invite Dr. Jayashree Sood, one of the bright anesthesiologists of this country. She's the chairperson of anesthesiology, pain and perioperative medicine at Sri Gangaram Hospital, New Delhi. She holds several key positions both in clinical and administrative roles. And I will be happy to announce that she was a recipient of Healthcare Excellence Award and Best Academician Award. And she is no doubt a popular teacher. And she is currently the CEO of Indian College of Anesthesiologists. I request Dr. Jayashree Sood to talk about the progress made by ICA in terms of publications. Dr. Jayashree Sood, please.
Good evening, esteemed faculty and dear delegates. Welcome to anesthesiologists for the second annual day celebrations of the ICA webinars being presented today as a special virtual event. As the CEO of the Indian College of Anesthesiologists, it's my proud privilege to inform you that the long-awaited Journal of Indian College of Anesthesiologists has now been launched. The chief editor of this journal is Dr. Kirtinath Saxena, Director Professor and Head of the Department of Maulana Azad Medical College, New Delhi. The editorial board consists of eminent national and international faculty. The publisher of this journal is Walter Clover. This is a bi-yearly publication, and the first issue of the online was published in May 2022 and the hard copies will be issued next month. The target areas of this journal are anesthesia, intensive care, pain, and research. It is my earnest request that all the delegates and faculty kindly access this journal by www.jicajournal.in and also give us your feedback and review about the journal. Would like to welcome you once again to this virtual program. Thank you very much.
Thank you, Dr. Jayashree Sood, for that wonderful description of the publications made by the Indian College of Anesthesiologists. Thank you very much for coming out with the journal. And we look forward to seeing the print version next month. Thank you very much. Next, I would like to invite Professor Baljit Singh, currently professor at SGT Medical College Hospital and Research Institute, Budhera, Gurugram, Delhi. He was previously at the GB Pant Hospital as the director and professor of anesthesiology and intensive care. He is a founder member and trustee of the ICA, and he shares the position of CEO along with Jayashree Sood currently for the Indian College of Anesthesiology. Dr. Baljit Singh, may I request you to tell us about the online education programs and other educational activities of ICA. Thank you.
Thank you so much, Dr. Kanchi Muralidhar. And good evening, friends from India, and good morning to all friends from across the seas. I'm delighted to tell you about the programs which the ICA is conducting at various institutions. One of the longest programs that ICA has been conducting is the liver transplant anesthesia and cardiovascular anesthesia. Now, the liver transplant anesthesia is going on for the last 6 years. The duration of this course is 12 months. And each year, there are 4 students which are taken. And this is being conducted at Medanta Medicity, and Dr. Vijay Vora from New Delhi is a course coordinator of this program. The next is the cardiovascular anesthesia program, which is being conducted by conducted at Narayan Hrudayalaya, Bengaluru. And this again is for a period of 12 months. There is intake of 6 students per year, January and July each year. And our dean, Dr. Kanchi Muralidhar, is the course director of this one. The next program again is at Narayan Hrudayalaya, Bengaluru, and this is on pediatric cardiac anesthesia. And the duration of this program is 12 months. And there is an intake of 6 students here also, January and July every year. And as I told you earlier, that the dean, ICA, Dr. Muralidhar Kanchi, is the course director for this program as well. The other program is onco-anesthesia, which is conducted at 3 different institutions. The first institution is Tata Cancer Hospital, Kolkata, and the intake of the students per year is 4, and Dr. Jyotsna Goswami is the course director. The second institution where this onco-anesthesia program is conducted, fellowship program is conducted, is Baswat Rakam Indo-American Cancer Hospital at Hyderabad. Again, an intake of 4 students per year. And Dr. Basant Kumar Riani is the course director. And the third institution where this course is going on, fellowship program is going on, is at Narayan Hrudayalaya. And Dr. Argya Mukherjee is the course director of this program. The other program that ICA is conducting is thoracic anesthesia fellowship. This program is again for a period of 12 months. And this is being conducted at Medanta Medicity, Gurugram. The intake of the students is 2 per year. And Dr. Sangeeta Khanna is the course director for this. The recent addition is regional anesthesia ultrasound guided Indian diploma in regional anesthesia, IDRA. This program was earlier conducted at Max Hospital, Saket, but because of some logistic reasons, they discontinued, and Sir Gangaram Hospital, Department of Anesthesia, led by Dr. Dr. Yashri Sood, they took it over. And this program is for a period of 3 months. It's an online course where there are weekly webinars which are conducted by the department. And at the end of the second contact program, there is an exit exam. It was just about 2-3 days back that the exit exam of the first program, IDRA, which was conducted at Sir Gangaram Hospital, was completed. And there is an intake of 30 students each batch. So this program is again very, very popular because there is a big demand from the students for the ultrasound guided program, ultrasound guided anesthesia program, nerve blocks, and other regional procedures. There are a few other programs which are under consideration by the ICA office, and I'm sure by the time we meet again, to celebrate third year of the webinars, there'll be more programs which will be added to the ICA teaching curriculum. Thank you so much. This is from me, and I hand it over back to Dr. Kanchi Murindar. Thank you very much.
Thank you, Professor Baljit Singh, for highlighting the educational activities which are being done under the banner of Indian College of Anesthesiologists. Thank you very much for joining us. Next, I would like to call upon Dr. Anupama Gotimukula. She is an anesthesiologist in San Antonio, Texas, and is affiliated with multiple hospitals in that area. And she received her medical degree from Kakatiya Medical College in Andhra Pradesh. And she has been in practice for about 20 years. She will be telling us about the association between ICA, possible association between ICA and AAPI, that is the American Association of Physicians of Indian Origin. Dr. Anupama Gotimukula, please.
Good morning. This is Dr. Kumar Belani. I'm one of the international deans of the Indian College of Anesthesiologists, and welcome Dr. Anupama Gotimukala, President of the American Association of Physicians of Indian Origin. Thank you for giving us a few words at the second anniversary of the webinars that have been conducted by the Indian College of Anesthesiologists that began during COVID in July of 2020. And so we are celebrating this by having presidents of different societies, including API. So welcome, and please share a few words with the Indian College of Anesthesiologists.
Thank you, Dr. Bilani Kumar, and thank you, Dr. Murli, and the entire leadership of Indian College of Anesthesiologists. And it's very impressive that the webinars went very successful, very high quality webinars. And about API, API is the Indian Doctors Association here in the United States. We call it American Association of Physicians of Indian Origin. And we are almost 40 years. We just had our annual convention a few weeks ago, and I successfully finished my term. And but as you said, last 2 years, yes, we have been mostly digital, and I think the ICA successfully had so many webinars, and hopefully they were so helpful to the physicians who attended. And I think API also would be happy to participate and collaborate coming up and in future We have a vibrant group of Indian anesthesiologists in the United States. I'm sure API has at least about 200 to 250 anesthesiology members in the API organization. So we do have a vibrant group, and we communicate very well all the academic related topics, and anyone has any pertinent questions related to our daily careers. And it's a vibrant group. We are connected, and I hope this will be we will have much more participation in the future coming up years, whether be it in webinars or in-person gathering. We would like to be very much involved. And anesthesiologists in the United States, we have many academic physicians who can be part of the ICA. If we have a chapter from API, that would be the best going forward. And I wish all of you very good luck and have much more activities related to our career, such a vibrant career. And we have several specialties here in United States, as Dr. Kumar practices here. Me being pediatric anesthesiologist, I work at Children's Hospital of San Antonio, Texas, and we are affiliated with Baylor College of Medicine. And so we do have academic guys here in our practice. And I think we have much more to do in future coming up years. And I thank you all, and I wish you all very good luck.
Thank you, Dr. Anupama. And I'm glad that an anesthesiologist was leading API for the year, and it was great to associate with you. And I'm sure with your leadership and with your connections with API, we can certainly make the ICA webinars and live meetings even more vibrant. And hopefully we can create more opportunities for the physicians in India who are part of the Indian College of Anesthesiologists. So we look forward to this Wednesday celebration and future connections with API. Thank you so much.
Thank you, Dr. Anupama and Dr. Belani. And I'm very happy that you mentioned about collaboration. And you also mentioned that we may have a API chapter in ICA. That's a great idea, and we will think about it and get back to you in the next few days. Thank you very much for joining us. Next, I would like to request Dr. Kohli to join us. He is the current president of the API, that is the American Association of Physicians of Indian Origin. He is an accomplished physician in the specialty of psychosomatic disorders, and he works at the Pennsylvania, United States, St. Francis Medical Center. I'm grateful that Ravi could join, and thank you so much, Dr. Ravi. And I would like to request you to say a few words and release one of the books published by one our faculty members recently, that is on onco-anesthesia. Dr. Ravi Kohli, please, current president of API.
Good evening. I hope all of you can hear me and see me okay.
Yes, yes.
And I am Dr. Ravi Kohli. I'm a psychiatrist here in Pittsburgh, Pennsylvania. I've been in practice for the past 30 years here, and I came from Rangaraya Medical College in Kakinada. It's my distinct honor and pleasure to represent AAPI, American Association of Physicians of Indian Origin, here today at your second anniversary of your webinars and activities. I'm so proud to participate here. Thanks for Dr. Belani for inviting me. And this was just a recent introduction of this program to me, so I don't know too much about it, not being an anesthesiologist. Of course, Dr. Anupama was a pediatric anesthesiologist, so she's much more aware of your activities and has been in touch with you. And Dr. Kumar Belani has been one of our leaders and a liaison person from academic as well as anesthesia faculty to Indian faculty. So we're looking forward to working together. And like Anupama said, AAPI is a 40-year-old strong institution of very highly reputed and respected across the board. We represent 120,000 physicians of Indian origin. We have about 100 plus chapters, patron chapters, including alumni, specialty, and various local chapters. And we have annual conventions, and we just concluded one. And actually, I'll be doing a global health summit in Visakhapatnam from January 3rd to 5th, or 6th to 8th. We have fixing the date. There'll be a weekend 6 to 8 most likely. So please come January 6 to 8, Visakhapatnam 2023. We're looking forward to having you there and have some courses provided by your team under the guidance of Dr. Belani and Dr. Anupama. As far as having some liaison, I'll ask Dr. Anupama to lead that along with Dr. Belani to formulate some plans and MOUs. Thank you, and I'm looking forward to connect with you more often. And it'll be my distinct honor to release the book that one of your faculty member has authored on onco anesthesia. So,
Thank you.
So this book is Onco Anesthesia, Critical Care in Cancer Pain by Dr. Josna Goswami from Sudipta Mukherjee, Neha Desai, and Rudrani Nandi. I wish you a successful launch and a great reception by the specialty of onco anesthesia. Thank you.
Thank you, Dr. Kohli. Thanks for joining us.
Yeah, thank you, Dr. Kohli, for at this short notice for joining us. We look forward to further collaboration.
Yes.
Thank you. Thank you.
Now I would like to request Dr. Naveen Malhotra, Professor of PGIMS Rohtak, Haryana. He is the Secretary of Indian Society of Anesthesiologists. He is the National Secretary of Indian Society of Anesthesiologists. And he has many accolades to his credit, some of which are COPS Award for Trauma and Critical Care, Best Paper Award in the ICA meeting, KPR Young Anesthesiologist Award, Padma Kant Award, and ICA Award for Academic Excellence. What a great tribute, the credentials. Dr. Naveen Malhotra, I think you're the right person to be the secretary for ICA and they climb the ladder from then onwards, upwards. With this, I would request Dr. Naveen Malhotra to tell us the vision for future. What do you think is in future for us? Thank you, Dr. Naveen.
Thank you, very respected Dr. Muralidhar Kanti, for such an elaborate introduction. I am humbled by it. Thanks to you. Very respected Dr. Radhakrishnan sir, my guru in ISA, Dr. Kumar Bilani sir, whom I had a long association at other platforms also, including RSSCP, Dr. Professor Randall Clark, President ASA, Dr. Ravi Kohli, President RPO, and Dr. Anupma, the past President RPO. Very, very respected Madam Jayashri Sood and Dr. Baljit Singh sir. I have grown as a student, as a child in anesthesia, listening to them, learning from them, and I convey my heartfelt gratitude to all of you on today's Guru Purnima festival, which is a major festival in India to pay tributes to our teachers and gurus. And what I can say for vision for future, I'm just a student in front of all of you, but I'll share my thoughts. I wish that we have uniform academic standards, not only at postgraduate level, but at undergraduate level also in the field of anesthesiology across the country. In each and every nook and corner of the country, in each and district, each state, each taluka, the academic standards which our anesthesiology postgraduate should practice, they should be of same level. And we have to continue to lead at the level of super specialties also. Like we are leading in the field of critical care medicine, we should continue to do that, as well as start more postdoctoral courses in different super specialties of anesthesia, like DM in pain medicine, and DM in onco anesthesia, so and so forth. And also, maybe we may venture into as an eligible candidates for DM in cardiology and neurology. We have to keep on working at the undergraduate level so as to catch them young, attract them towards the field of anesthesiology. Not only academics, but we have to also focus on those anesthesiologists who are not working in institutes, who are working in nursing homes. We have to train them also. It is our moral responsibility to keep them updated academically as well as clinically. For that, we should have more and more skill centers where they can undergo training either simulation based or as a clinical observership. Lots and lots of MD seats of anesthesiology, the postgraduate seats of anesthesiology have increased in our country. So it is imperative on all of us to maintain adequate level of teaching, training and research. We have been saying that the number of anesthesiologists across the country were less, but now more number of anesthesiologists are coming after their post-graduation. We should ensure that they are appropriately trained clinically, academically, and in research during their post-graduation. It is imperative on us to maintain gender equality also, whether in the department level or at the administration level or at the level of associations. We have to teach our colleagues, not only academics, clinics, but also to maintain the work-life balance. Anesthesiologists should be seen as a true leader, whether it is the administration at the level of the institutes or at liaising with the government. We should be strong enough clinically, academically, that government and other authorities should listen to us while they are formulating the policies at the national and international level. We have to continue to move out of the OTs. There is a role of anesthesiologist in community health also. And yes, we have to explore the avenues what an anesthesiologist can do in public health. Today, I am very happy to see, and it's a feeling of pleasure also and pride also, that following me, all the state branch presidents of ICA National, they will be sharing their views on hot topics in anesthesia. COVID has given us an opportunity to ignite the fire of academics at each level. I heartily congratulate ICA for completing successfully 2 years of non-stop webinars, and the credit must go to the whole of the leadership of ICA. And this is continuing at each level also. Lots and lots of webinars and programs are being held at different levels. And last but not the least, we should keep on progressing like this in all the fields of anesthesiology, and all the associations across the country of anesthesia should work cohesively to serve the mankind as they have served in the recent COVID pandemic. I once again congratulate the ICA leadership and for inviting me here to share my thoughts. Thank you very much.
Thank you, Dr. Naveen Malhotra, for that excellent view on vision for future. I really appreciate that you mentioned that we should catch these medical graduates when they are young, during their undergraduation, and also you highlighted the importance of adequate training, gender equality, work-life balance, and leadership role of anesthesiologists. Thank you very much for your message, and we will look into all these aspects and move forward. Before I actually hand over the podium to Dr. Sanish to conduct the hot topics in anesthesia by the state presidents, I would like to announce the release of Journal of Acute Care. This journal is being released digitally. It has been released in the nationwide, and the print version will be released in about week's time at Bangalore. I request contributions in anesthesiology, critical care and emergency medicine, original articles, any other manuscripts relating to these specialties will be welcome. Thank you very much. And now I hand over the stage to Dr. Sanish to conduct the hot topics in anesthesia. Each deliberation will be done by the corresponding state presidents of Indian Society of Anesthesiologists. And I am looking forward to this event. Thank you so much, Dr. Sanish. She is the academic coordinator of Indian College of Anesthesiologists. He has done immense work for the development of webinars, and he has devoted a lot of time and effort to see that these programs are successful. I would like to especially thank Sanish for doing this wonderful job. And Sanish, the floor is yours now.
Thank you very much. I am truly proud and happy presenting before you hot topics in anesthesia on this special occasion of the second annual day celebrations of ICA webinars. With due thanks and regards to the entire leadership of ICA, I am Dr. Sanish, Coordinator, ICA Academics, taking you through the special presentations by the state presidents of Indian Society of Anesthesiologists. Let's get going. Shall we start with opioid-free anesthesia? Are we ready for the change? Please welcome Dr. Jyoti Pathania, President ISA Himachal Pradesh. Over to Dr. Jyoti.
Good evening, everyone. Today I shall be discussing on opioid-free anesthesia. Are we ready for the change? So the opioid-free anesthesia evolved because of the opioid misuse crisis, and it resulted in opioid public health emergency declaration in 2017, which advocated research in the practice of pain management. Opioids are known to cause opioid-induced hyperalgesia. There is increased risk of tumor recurrence, and even enhanced recovery protocols support OFA and opioid-sparing strategies. So what is opioid-free anesthesia? It is a balanced multimodal approach with multiple drugs and techniques used alone or in combination in a rational and defined manner without any use of opioids. And these are the various drugs which are tried for OFA. Seeing the various pain pathways, NMDA antagonist, alpha-2 agonist, anticonvulsants, and local anesthetics are used for this purpose. Ketamine in sub-anesthetic dose is a potent analgesic, but it has disadvantage that it increases the muscle tone, increases salivation, emergence reaction, hallucination, and is relatively contraindicated in hypertension, schizophrenia. Dexmedetomidine has been reported to have serious adverse events like bradycardia, hypoxemia with equal and less PUNV. Pregabalins and gabapentinoids in 97 trials, a meta-analysis, it was found that it was not recommended due to nausea, sedation, dizziness, vomiting, and visual disturbances. Lignocaine has unlicensed use for post-operative pain in an international consensus statement on efficacy and safety of the anesthesia because its use can be fatal when used inappropriately and incorrectly. So opioids are still unchallenged supreme analgesics. There is no clear or significant benefit of OFA over opioids. Opioids' role in tumor recurrence is controversial. OFA drugs are costly, not easily available, and may require advanced monitoring to measure the intraoperative nociception. So relative indications for OFA could be OSA, CRPS, substance abuse patients, patient with history of increased PONV, geriatric patients, and in bariatric surgery. So I conclude, at present, opioid eradication seems like a difficult goal to achieve. We should still consider judicious use of opioid strategies, that is opioid sparing over OFA, till the advent of other potent and safe analgesics. So patient safety should be our priorities. Thank you.
That was thought-provoking, isn't it? You are watching the second annual day special virtual event. Now let us welcome Dr. Sukanya Mitra, President ISA Chandigarh, to speak on chronic post-surgical pain, new frontiers. Over to Dr. Sukanya.
Good morning. Thanks to the organizers for making me a part of this ICA webinar. So I'm going to talk about chronic post-surgical pain and new frontiers. So what is chronic post-surgical pain? Why should I care? And what is new? Now, as the name suggests, this is one of the most frequent complications after surgery, and in median incidence about 20 to 30%, and range is about 5 to 85%. Now, why this has come into the limelight? Because in 2019, WHO gave chronic CPSP a separate status with chronic pain disorders. And what is more important is that it raises the awareness of the condition as a disease rather than merely a symptom. And therefore, there lies the need for finding specific treatment and management. Now, as per definition of ICD-11, any pain that persists beyond 3 months after the triggering effect, it is localized in the surgical area or innervation area of the nerve in this area or the dermatomal area of that nerve. And it often shows characteristics of neuropathic pain, and the other causes like pre-existing painful conditions, infection and malignancy are excluded from the differential diagnosis. Now, what are the risk factors? We categorize before surgery, during surgery, and after surgery. So there are many risk factors, but consistently strong risk factors are pre-surgical, where there are young, anxious female, catastrophizing pain, pre-operative pain and opioid use, Then in the from the surgical point of view, it's the usually longer duration of surgery with complications and found more commonly in amputation, thoracotomy, and mastectomy. After surgery, these patients complaints of prolonged postoperative pain, and the hallmark is they have a neuropathic character of pain. So are there any tools to predict? Well, there are a number of tools, at least 11, non-clinically useful. This is a head of print article of BJA where the authors have worked with two models, and they predicted that there are 4 items like orthopedic surgery, preoperative use of opioids, high pain intensity, and painful cold area within the pain area on 14th day after surgery are strong predictors. Now, how to prevent this? Many studies, but overall disappointing results. Then how to treat once developed? Again, no clear winners. Many drugs can be used. However, reduction of opioid use using multimodal analgesia, regional technique before and after during anesthesia, or by use of ketamine shows promising effect. Again, this is a new ahead of print study which gives a light to the end of a tunnel, which shows that dexketoprofen and tramadol combination when used in patients of post-surgical chronic pain has a good future. Now, all pain management are biopsychosocial approach is very useful in the management. And however, the Lancet group in 2019 moots the idea of transitional pain services, which is an interdisciplinary pain team that aims to close the gap between acute postoperative pain management and pain management after discharge from the hospital. So this is the new model. I conclude saying that this is a common, debilitating, and difficult to treat condition. However, it is important to identify risk predictors, and although preventive and management options need much further work in this area. Thank you very much for your attention.
Thank you, Dr. Suganya Mitra, for bringing this topic on our second annual day of ICA webinars. Now it's over to Dr. Shamsad Begum, President ISA Kerala State Branch, to highlight the use of cuffed endotracheal tubes in pediatric anesthesia. Over to Dr. Shamsad.
First of all, I take this opportunity to thank the organizers for giving me a chance to participate in this, especially Muralidhar sir as well as BRK sir. My topic for today's presentation is cuffed endotracheal tubes in pediatric anesthesia. The clinical significance is that the narrowest part of the airway is at the cricoid ring. Traditionally, we prefer to use in children up to the age of 6 years, the uncuffed tracheal tubes. To minimize induced damage of tracheal mucosa, as well as to reduce the airflow resistance by inserting larger size tubes. The benefits of uncuffed tubes are, it includes the decreased need of tube exchangers, especially in the operation theatre and the pediatric ICUs, and also while transporting the patient. Increased effectiveness of delivering positive pressure ventilation when pulmonary compliance worsens, increased protection from microaspiration, and also less gas pollution in the operation theatre. The cuffed tracheal tubes are designed to provide a seal within the airway, allowing airflow through the endotracheal tube and to prevent passage of air or fluids around the tubes. Historically, uncuffed tubes were preferred up to the age of 8 years. Now, we commonly prefer to use cuffed endotracheal tubes in neonates, infants, and young children. The thin cuffed endotracheal tubes have got a cylindrical shaped cuff of about 10 microns millimeter size, as well as the cuff volume is up to 10 centimeters of water, and there is absence of Murphy size, which is also compromised by the presence of this cuff, the cylindrical cuff, so that the disadvantage is the additional passage for the airway is lost. This is the picture of a micro thin cuffed endotracheal tubes. It shows the cylindrical difference between the cuffed and the uncuffed endotracheal tubes are the cuffed endotracheal tubes allows the use of low fresh gas flow, less use of inhalation agents so that it is it's economical, reduced air pollution, reduced risk of aspiration, that avoids multiple laryngoscopies and intubation attempts, and improved ventilation and end-tidal carbon dioxide monitoring is also allowed. Whereas in cuffed endotracheal tubes, it has got larger inter-abdominal diameter, lower resistance to airflow, prevents increase in work of breathing, allows easy suctioning, avoid trauma to the subglottic region. Is that the cuffed endotracheal tube may be used in neonates, infants, and in young children. The advantages are it provides a seal within the airway, allowing airflow through the endotracheal tube, and while thank you. My
That was a crisp and clear presentation. Thank you very much, Dr. Shamshad. Now it's over to Major General Dr. Rashmi Datta, President of the Society of Defense Anesthesiologists of ISA, to enlighten us on the role of ultrasound of the lung in the emergency department.
At the onset, I would like to thank the organizers for giving me this opportunity to speak about the ultrasound of the lung in the emergency department. The ultrasound, in comparison to the conventional imaging modalities which are available, it is easily available at the bedside. It is real time. It is free of radiation hazards. The blue protocol is followed. It takes less than 3 minutes for the diagnosis of acute respiratory failure. Now, this blue protocol has been further modified for the diagnosis of ARDS, which was used extensively during the COVID pandemic as the pink protocol. And for acute circulatory failure, it has been adapted as the false protocol. Now, the principles of lung ultrasound are that lung is a very common target for many disciplines, and the B profile can show pulmonary edema, A profile can show hypovolemia. It is superficial, extensive, and standardized areas can be defined. There are standardized signs also with a very low risk of false or wrong interpretations, because in the lung you have gas and fluid have got different locations, and they create the artifacts, and all the acute life-threatening disorders abut the pleural line, which is easily recognizable, and from there, since they start from there, they are usually dynamic, and static signs, if present, are usually artifactual. And this is performed using a simple equipment with minimal adaptation. There are 6 zones which are taken in the blue protocol: anterior, lateral, and the slightly turning the patient to the opposite side, the flaps point. Now, 2 hands are placed of the sides of the patient only are placed on the anterior surface. The middle of the upper hand is taken as the upper blue point. The middle of the lower hand is taken as a lower blue point, and the intersection of 2 lines, that is the horizontal line and a vertical line, is taken as the flaps point, which is slightly in the posterior aspect, and the Merlin space is seen below the lung pleura. The various profiles which have been defined includes A profile, which is lung sliding, with that is the movement, shimmering, phasic shimmering, which is seen with each respiration. With A lines. A lines are multiple artifacts which look like the pleural sign, which are coming below the lung. Then B profile is with sliding and lung rockets. Now, lung rockets are, comet-like artifacts which come into the lung tissue. A dash profile and B dash profile are without the lung sliding, but with A profile and B profile respectively. Then there is a C profile also. Now, remember one thing: ultrasound is usually done considering the anterior lung. Now here there is consolidation, even if there is a thickened irregular pleural line that is taken as an equivalent. Then there is an A and B profile, that means half this side and half that side, A profile here and A profile B. Plabb's profile is seen when there is A profile, that means there is pulmonary embolism plus free venous network, and if there are free veins and Plabb sign is positive with the A sign, so known as AV Plabb's profile. Now, this is the protocol which is generally followed. Either the lung sign is present or abolished. If it is present, it is A profile or B profile. B profile is pulmonary edema. A profile, then we check for the sequential venous analysis. If there is thrombosed veins, then it is pulmonary embolism. If it is free veins, then it is further taken as Plabb's, either pneumonia or COPD and asthma. If it is abolished, lung sliding is abolished, then B dash is taken as pneumonia. A dash is then the lung point is checked, which is a line in which there is either all or none. Suddenly there is lung sliding, and at one point there is no lung sliding. If that is present, it is pneumothorax. If that is not, then we need further diagnosis. It has certain limitations, like visual. Their dressings and subcutaneous emphysema may hamper the view, and interpretational difficulty, especially for exceptional cases, and there's a steeper learner curve. Thank you very much.
Thank you very much, Major General Rashmi Datta. Okay. Newer anti-diabetic drugs have been a challenge to the anesthesiologists, especially in the last decade or so. Dr. S. Kumar, President ICA Tamil Nadu State, will be elaborating on SGLT2 inhibitors and its anesthetic implications. Over to Dr. S. Kumar.
A very good morning to everyone. At the outset, I would like to thank the organizers of ICA, especially Professor Kanji Muralidhar sir, for inviting me to be part of this second anniversary ICA celebrations. In the next 3 minutes, I'm going to talk about SGLT2 inhibitors and its anesthetic implications. There are various diabetic drugs available for the treatment of diabetes. It acts on the various systems, in that SGLT2 inhibitors acts on the kidney. The sodium glucose co-transporter 2 inhibitors acts on the proximal convoluted tubule. It inhibits the reabsorption of almost 90% of the filtered glucose load. Thereby, it increases the urinary excretion of glucose, which leads on to reduction in the plasma glucose. So by increasing glucose excretion, osmotic diuresis and natriuresis, it improves the cardiac function. It also reduces the blood pressure, weight, and improves the renal function. There are various SGLT inhibitors available in the market. On that, empagliflozin, dapagliflozin, canagliflozin, and remagliflozin are in practical use. Other than reducing the plasma glucose, it also reduces the weight and BP, and it significantly reduces the risk of hospitalization for heart failure and improves the renal outcome. There are few reported side effects: genitourinary infections and rarely euglycemic ketoacidosis, bone fractures, and lower limb amputations. Various cardiovascular outcome trials have clearly shown that it reduces hospitalization for heart failure by 35%, CV death by 38%, and 3-point MACE by 14%. ADA and EASD has clearly shown that next to metformin and lifestyle as a first-line drug, and these SGLT inhibitors are indicated as a second-line drug in patients with atherosclerotic cardiovascular disease, heart failure, and CKD. As per the European Society of Cardiology, SGLT inhibitors indicated as a class 1 recommendation in patients with the treatment of diabetes and patients with diabetes to reduce the heart failure risk, and also a class 1 recommendation for patients with the diabetes and chronic kidney disease to improve the renal outcome. Something about SGLT inhibitors in the period. As I said earlier, SGLT inhibitors increases the glucoseuria, thereby it reduces the plasma glucose and leading on to a reduction in the insulin release from the pancreas, which ultimately lead to increased production of ketone bodies in the liver and ketoacidosis. So the factors which precipitate ketoacidosis in patients with SGLT inhibitors are infection, volume depletion, and surgical stress. So we should stop these SGLT inhibitors at least 3 days before scheduled surgery to reduce the risk of developing ketoacidosis during and after surgery. We should have caution when we use these SGLT inhibitors in patients with a risk of volume depletion, history of recurrent UTIs, improper genital hygiene, and conditions of fasting. So to summarize, SGLT inhibitors has a proven cardiorenal benefits and useful for the treatment of heart failure in patients with and without diabetes. The various guidelines clearly suggest that there is a preferential use of SGLT inhibitors in patients with atherosclerotic cardiovascular disease, heart failure, and CKD, irrespective of the hemoglobin and diabetic status. And these agents should be stopped at least 3 days prior to surgery to avoid eglycemic decay. In patients with SGLT inhibitors who are undergoing emergency surgery, we should avoid volume depletion, dehydration, and observe caution towards the occurrence of diabetic ketoacidosis. With this, I once again thank Professor Kanji Muralidhar sir and end my talk. Thank you very much.
Yes, it is very important topic presented in a very interesting manner. Thanks, Dr. Kumar. We are continuing with hot topics in anesthesia on the occasion of the second annual day celebrations of ICA webinars, the Wednesday evening online academics since 15 July 2020. The next hot topic is oral anticoagulant drugs and their anesthetic implications, and we have with us Dr. Anita Kohli from ISA Jammu to take us through. Over to Dr. Anita.
Good evening, everyone, and thank you, ICA, for having me here. My topic for today's discussion is direct acting oral anticoagulants and their anesthetic implications. Traditionally, parenteral anticoagulation is done with heparin and its analogs, and for chronic settings, vitamin K antagonists. Coming to the novel or newer or direct acting or target oriented oral anticoagulants, we have got dabigatran, rivaroxaban, and apixaban. The advantages of these over traditional anticoagulant therapy is that they've got rapid onset and offset of action, predictable anticoagulant action, no need for routine monitoring. They have got specific enzyme action with low side effects and fewer drug restrictions and low drug interactions. Coming to the indications, apixaban, dabigatran, and rivaroxaban, they are given for thromboprophylaxis in patients undergoing hip or knee replacement surgeries, and in stroke prevention for patients with atrial fibrillation, which is perhaps their most important use. In addition, rivaroxaban is also given for treatment and prevention of deep vein thrombosis and pulmonary embolism, and it is the only FDA-approved drug which is used in MI patients in acute coronary syndrome. Now, the patients can come to us for elective surgery, for emergency surgeries. There can be overdose of the oral anticoagulant drugs, or there can be bleeding with these drugs. Patient can come with trauma. So we have to see the perioperative management of the patients. The most important thing to remember is that the role of bridging therapy is not there. Coming to the drug interactions, it has got a lot of drug interactions, especially in drugs which have got a common pathway of metabolism. Then the coagulation test. The patients on NOACs, they have a predictable anticoagulant effect, so no routine coagulation monitoring is required. But there are certain situations which require urgent testing, that is before surgery or any invasive procedure, when the last dose of NOAC is within 24 hours. or patients who are bleeding, or if there's an overdose of these drugs, or if there's a renal insufficiency, hepatic insufficiency, or a patient of thrombosis on treatment who's posted for surgery. Then we go for the standard coagulation tests for this. Comparative risk assessment is important because we have to strike a balance between the risk of thrombosis and the risk of bleeding. Now, if the patient has had a VTE within 3 months, then there is a more risk of thrombosis, whereas a risk of bleeding depends on the patient, or it depends on the type of the surgery which we have to do. Supposing a patient, the age is more than 80 years, or if the body weight is less than 50 kg, or if there's a renal insufficiency, or if there is a hepatic insufficiency, then these patients are more prone for bleeding. And also it depends on the risk of the procedure. Like we have low bleeding risk procedure like the skin abscesses and all that, and ophthalmic procedures or breast surgery, or low or intermediate bleeding risk procedures like cholecystectomy or hysterectomy, and high bleeding risk procedures like open cardiac surgery, vascular surgery, neurosurgery, joint replacement, especially more than 2 joints, or laminectomy. So when do we start? When do we stop these drugs, and when do we restart them? So for minor surgery, for almost all NOACs, we stop 2 days before the surgery. And in case a patient has got renal impairment, then we stop 3 days before surgery. And for major surgery, we stop 3 days before surgery for all NOACs. And for starting the drug post-operatively, we restart 24 hours after surgery for minor surgery, and 48 hours after major surgery. And if we have to give central neuroaxial blockade, it is very important because those patients which have to be given central neuroaxial blockade, they are taken as major surgeries. For dabigatran, we have to stop for 5 days, and for rivaroxaban and apixaban, we stop for 3 days, and we start the drugs again after 6 to 8 hours after spinal or epidural puncture, or after removal of the epidural catheter. Now, in case a patient comes to us for emergency surgery, it is very important that we know the time of the last dose, and the acceptable last dose time is more than 24 hours. But in case it is not there, then we have to go for estimation of the plasma levels of NOACs. If it is less than 30 nanograms per ml, then there is no risk. If it is between 30 to 200 nanograms, then it is intermediate risk. And if it is more than 200 nanograms, it is high risk. These are my references. And thank you again.
Thanks, Dr. Anita. It was really captivating detailing of the topic. Our next hot topic in the second annual day special ICA webinar is contactless monitoring by Dr. H.G. Manjunath, President ISA Karnataka State Branch. Over to Dr. Manjunath.
Hi everyone, good evening. Greetings from ICA Karnataka State Chapter Karnataka. I am Dr. H.G. Manjunath, Professor under the Department of Anesthesiology, Mysore Medical College and Research Institute, Mysore. Today I am going to speak on contactless monitoring. Monitoring is essential for patient safety. Patients admitted to the hospital are at a high risk of clinical deterioration, and monitoring is useful to detect this at a very early stage. It also helps to prevent serious adverse events and ICU readmissions. Coming to the Indian scenario, we have 440 crore populations, but only 20 lakh hospital beds are available in India. That means to say that 1 bed per 700 people. As of April 2020, before COVID hit us, the number of ICU beds in India were only 27,360. By the end of January 2021, we had about 36,000 ICU beds, which are added a change of 10K in 1 year. So this statistic shows the distribution of government hospitals and beds across rural and urban areas. But 4.2 million deaths occur globally each year due to post-operative complications. Currently, the only patients in the hospital who are continuously being monitored are patients in the telemetry, intensive care units, and those in the operating room. Ward patients are monitored only by spot checks done every 4 to 6 hours, leaving the patient unmonitored for almost 98% of the time. There is still more. Every time there is an emergency situation, there is always a trend of deteriorating vitals 6 to 8 hours before that event occurs. This leads to escalation in care, leading to longer length of stay, higher cost, and also negative clinical outcomes. To top it all, doctor to patient ratio in public healthcare setup in typical Indian scenario is 1:15. Nurse to patient ratio in public healthcare is 1:25 to 1:40. When ideally it's supposed to be a nurse to patient ratio of 1:4 as per WHO. So the current system of monitoring is not optimal in Indian scenario. So we have to answer three questions. Is there a way for clinicians to be proactive rather than reactive? Can we add more nurses and doctors to the healthcare system overnight? Can we stuff more ICU beds to meet the need? The solution is, we live in a world where smartphones and smartwatches can be used to monitor pulse rate, detect arrhythmias, and to measure oxygen saturation and to record ECG and non-invasive blood pressure using mobile apps. With the help of artificial intelligence, now it is very much possible to upgrade the monitor system in wards and also in ICU settings. So what are they? There are two types are available now. Contact-free sensors are stay in the bed monitor solutions. They are either bed sensors or video cameras. Bed sensors are usually the piezoelectric pads which kept below the bed mattresses. Wireless wearable sensors or mobile monitor system include necklaces, finger sensors, and adhesive patches. These two types of sensors can detect the hemodynamic indices continuously, and we can read through our mobile or through the monitors. Remote continuous wireless monitoring on the wall through artificial intelligence guided detection of early warning signs may circumvent many of the above problems. So to summarize, monitoring should ideally be contactless and minimally intrusive. So the need of the hour is remote contactless telemonitoring of critical patients on the ward along with the inbuilt artificial intelligence based warning symptoms to enable quick triage of patients who deteriorate and need to be shifted to the ICU. Thank you.
Thanks, Dr. Manjunath. Your presentation carries a lot of information for the practicing anesthesiologist. We are in a special ICA webinar on the occasion of second annual day of ICA webinars. The next hot topic is recent advances in neuroanesthesia. We have with us President of ISA Maharashtra State Branch, Dr. Manisha Katika. Over to Dr. Manisha.
Respected Chairperson and respected Dr. Kanchi sir, thank you for inviting me here. Myself, Dr. Manisha Katikar, Chief Anesthesiologist and Intensivist practicing at Balwant Institute of Neurosurgery and Intensive Trauma Care, Sholapur. The topic allotted to me is neuroanesthesia recent advances. The topic is really so vast, so I decided to include the recent guidelines which are published in this month only in July 2022 in Journal of Neurosurgical Anesthesiology. These are the clinical practice guidelines from the Society of Neuroscience in Anesthesiology and Critical Care, and these guidelines are regarding perioperative care of patients undergoing major complex spinal instrumentation surgeries. We all are aware that there has been a significant increase in the spine procedures, particularly the primary lumbar fusion procedures. And major complex spine surgery, as per this article, is defined as surgery which involves two or more levels of the spinal column and are associated with any of the complications. So these guidelines are aimed to provide evidence-based recommendations, and they include various parameters that are related to anesthesia as well as non-anesthesia care for that patient, which are relevant to pre-hospital, pre-operative, intraoperative, and post-operative phases of care. The various class of recommendations are class 1 strong, class 2A moderate, class 2B weak, and class 3 either no benefit or harm. Then various levels of evidence are level A, which has a high quality of evidence, level BR, that is with randomized studies, level B NR, that is with non-randomized studies, level CLO, that is with limited data, and level CEO, that is with expert opinion. So in various pre-hospital parameters, all the factors have received good strong evidence, the class 1 evidence, and Various identification of reality assessment and identification of risk factors has been given importance. In the anesthesia technique, importance of monitoring, neuromonitoring has been given importance, and all of them have got class 1 recommendation in intraoperative anesthesia technique. In perioperative analgesia, methadone, wound infiltration, alpha-2 agonists have got class 2 evidence, while patients with while neuroaxial anesthesia and other non-neuroaxial anesthesia have got class 2B evidence. In another perioperative factors, patients who are receiving antithrombotic therapy, especially that tranexamic acid, has got class 1 evidence and a strong level of recommendation. Also, giving antibiotics to the patients in the first 60 minutes before incision also receives class 1 evidence. And also has good level of recommendation. So to conclude, many of these recommendations in these practice guidelines have moderate to low level and lack a high level of supporting evidence. However, ongoing and future multi-institutional studies may allow for stronger recommendations with higher quality evidence. So anesthesiologists should incorporate new evidence into the local practices as it becomes available. Thank you very much.
Thank you very much, Dr. Manisha. With the limited time, you have enlightened us on the recent advances in neuroanesthesia. Moving ahead, let us welcome Dr. Edil Rajan, President ISA Puducherry, to speak on another important topic, critical care in obstetrics. Over to you, Dr. Edil Rajan.
Yeah, good morning, all. I'm Dr. Edil Rajan, a professor at the Department of Anesthesiology, working in our body with Medical College, Puducherry. And regarding the ICA webinar in Indian College of Anesthesiologists, I'm going to share few points about critical care. Mainly, I focused on critical care in obstetrics. And you know that obstetrics anesthesia is always challenging, invariable of whether you are postgraduates or expert consultants. And the clinical situation always is a life-threatening one, and it requires immediate action and team management. And also, here too, hemodynamic stability is a prime target for the things with various modalities of managing with fluid replacement with crystalloids and colloids, vasopressors, inotropes, blood and blood products. And overall, to aim what's the primary cause which causing this hemodynamic stability and critical crisis state for the patients. And you have to treat it with appropriate team management. For example, take a case of atonic PPH. The situation is not at all an anticipated one, neither by the anesthetist nor by the obstetrician. A sudden onset of bleeding and hypotension can mostly probably at the end of surgery. And also obstetrician will come to know this complication at the end of the surgery only. Our aim should be the managing ways to stop further bleeding and keeping the patient hemodynamic stability with the drugs as well as fluid management. It gives challenge to anesthesiologists and the obstetric team for better outcome of the patient without any morbidity mortality. Thank you all for the opportunity.
Thanks, Dr. Edil Rajan, for bringing this topic on this forum. I'm sure it is well appreciated by one and all. Our next hot topic presentation is about critical care in COVID-19, and we have with us Dr. Geeta Bhandari, ISA Uttarakhand State. Over to you, Dr. Geeta.
Good evening, you all. Thanks to ICA. I will talk about COVID-19 and critical care, our experiences with the COVID and lessons we learned. I begin with COVID-19 lessons. COVID has taught us what is life and what is death. Humankind witnessed a great loss of life. It exposed the weaknesses of the human system to fight the disease. Importance of good behavior and cleanliness was recognized. In this country, with the huge population and variety of people with different cultures, intensive care facilities were almost negligible. Most of the hospitals deficit Most of the hospitals did not have the beds with oxygen. In India, first ICU was established in 1970 in Mumbai. Organization of ICU services till the pandemic was limited to few centers across the country. During pandemic, we started looking for oxygen, gas pipeline systems, ventilators, PPEs and other equipments. We had few people trained in ICU care of the critically ill patients. At the same time, different departments struggled to make policies. New ideas emerged from these discussions and new challenges that the healthcare system faced. COVID-19 still continues to be a threat. Transformation of the healthcare system for the future emergencies is a big challenge. A model of the critical care system in future is presented here with courtesy to Journal of Intensive Care Medicine, where effective trials, expendable bed capacities, safer ICU design, efficient supplies, expendable ICU staffing, effective registries, and artificial intelligence will be involved. The focus is on well-being of healthcare workers as well. In conclusion, best results from the ICU can be obtained by cooperation, collaboration at local, regional, national, and international levels. We must focus on improving our knowledge and skills. We should analyze and evaluate the results of our strategies, whether good or bad, useful or helpful. Innovations and research will always help to improve the healthcare system. Thank you.
That was an interesting topic and presentation. We regret the technical glitches though. Thanks Dr. Geeta for your participation. Now we are moving to our next hot topic presentation. It is on COVID care by Dr. Rukhsana Najib, President ISA Srinagar. Over to Dr. Rukhsana.
Good morning, everyone. I'm Dr. Rukhsana, heading the Department of Anesthesia Critical Care at GMC. I have more than 30 years experience in the subject. I'm a member of Indian Medical Association, Indian Society of Anesthesia, Research Society of Anesthesiology. I have a lot of publications to my name, and I go on attending workshops, CMEs, conferences, and panel discussions at the national and the international level also. My area of interest these days was COVID care because we have been managing COVID since last 2.5 years. It's a highly contagious viral illness caused by SARS-CoV-2. It has resulted in more than 6.3 million deaths worldwide. The doctors around the world, especially anesthesiologists, have been on the forefront in saving the critically ill COVID-19 patients. Whether in the OTs or in intensive care, we work tirelessly to save our patients. So this was one of the side effects of prolonged use of N95 mask. Despite of all the challenges, healthcare workers in GMC and associated hospitals, we work tirelessly and selflessly to serve the patients. Our hospital not only treated COVID-19 patients, with the existing facilities, but also established new ICUs and wards for these patients in CD hospital, DRDO, and super specialty. This is the round of ICU ward 10. COVID, it was purely a COVID-19 ward. So at the same time, we take care that non-COVID patients do not suffer, and this is the bariatric surgery. This is the super specialty hospital ICU, which was a non-COVID ICU. Protocols were developed to focus on the clinical decisions regarding the intubation, use of high flow oxygen and non-invasive ventilation. Bedside ventilators, high flow nasal oxygen, NIVs, monitors, and oxygen plants were provided by the government during pandemic to improve the healthcare. Modalities of treating COVID-19 patients by providing oxygen therapy, like nasal prongs, face mask, non-rebreathing reservoir face mask, high flow nasal cannula, NIV, and invasive ventilation were tried. Currently, the use of FNC and NIV is reserved for severe hypoxia. So these were the equipments we got during COVID-19. We shared our experiences of managing the patients at various national and international conferences. These interactive sessions helped us in updating our own protocols for management of COVID patients. This was, one of us was the main speaker here regarding respiratory support. At the same time, we made sure that we do make people aware about the use of vaccination and following the protocols of SOPs for COVID-19. Thank you.
Yes, in this pandemic time, this topic remains very much highlighted. Thanks, Dr. Rukhsana Najib. We have one more hot topic to go for this discussion today. Please welcome Dr. Viresham, President, ISA Telangana State, for his talk on the use of laryngeal mask airways in NORA, non-operating room anesthesia. Over to Dr. Viresham.
Good evening. I am Dr. Viresham, Professor Anesthesia, James. Now I am going to deal with the LMA in NORA area. LMA is having well regarded place in emergency airway management in NORA. It is useful in providing rescue ventilation and oxygenation, and even in intubation. It works as an intubation conduit and intubation introducer in flexible fiber optic endoscope. The LMA is available as immediate control of airway in NORA areas, and it is accepted device in difficult airway, cartoon, and emergency care doctor. It is very easily learned by the perioperative physicians and the doctors of emergency care. LMA maintains the airway patency until the trachea is secured, and intubation can be blindly and reliably can be done through the LMA. It is having distinct advantage over the fiber optic, flexible fiber optic conduit. Intubating MLA models are intubating LMA, LMA fast track, Teleflex. More claims of morbidity and mortality have been reported in NORA area from 2000 to 2016 compared to regular OT. It will happen usually in GI suits, cardiology and radiology, pediatrics and burns and psychiatry areas. As a perioperative physician, we should learn to say that they know wherever the facilities are not adequate, like in NORA areas like interventional pulmonology, endoscopy suits, interventional radiology and radiodiagnosis area, cardiac cath lab, burns area, outpatient dentistry, and sometimes pediatric sedation in the pediatric wards. LMA is contraindicated in some major trauma, with including facial-maxillary injuries and non-fasted patients, bowel obstruction patients, emergency surgeries, and those chronic diseases which will manifest in the delayed gastric emptying time, and those patients who are having less than 2 centimeters of mouth opening, and those patients who are having pharyngeal tumors also, they are contraindicated. Some relative contraindicated: recent abdominal major surgery, pregnancy over 14 weeks, and prone position, airway surgery, laparoscopic surgery, obesity more than 30, BMI, and decreased lung complaints, and altered mental status. Known complications with LMA are liberal application of jelly can lead to sore throat, laryngospasm, and cough. Sometimes due to LMA manipulation, folding of epiglottis can lead to obstruction. And sometimes failed LMA is noted in 1 to 5% of patients. And this can also lead to tension pneumothorax due to increased cough pressure over than 60 centimeters per day. And it also leads to like increased edema, pulmonary edema, laryngopharyngeal edema. These are things which are likely to happen in NORA areas. Some of the takeaway messages in NORA area with LMA is wherever the call comes from the NORA area to the anesthesiologist, reach the place in advance. Don't proceed without any minimum equipment like suction, oxygen, airway cot, and emergency drugs, and minimum monitoring equipment. And not only that, even IV access should be there. And you should also have trained staff in which, and you should communicate with the patient and the operator and staff, patient attendants with their parents, and train the staff, or otherwise you bring your own assistant. Whenever you face a situation like anxiety and tension, and the situation is very dramatic, then at that time you should be like Atmanirbhar. Thank you very much.
Well, indeed, that was a truly amazing collection of hot topics in anesthesia. On behalf of ICA academics, I extend my sincere thanks to all the speakers. And it is time to welcome Dr. Manjula Sarkar, Trustee, Indian College of Anesthesiologists, for the formal vote of thanks. Over to Dr. Manjula Sarkar.
I am proud, privileged, and honored to say vote of thanks for this memorable and going to be historical webinar for second annual day celebration. This is a unique kind of the program. Dr. Bilani, Dr. Mulli Kanchi, and Dr. Radhakrishnan, thank you, sirs, for organizing this program for us. I thank Dr. Venkatgiri, Dr. Clark, Dr. Jayashree Sood, Dr. Baljit Singh, Dr. Anupama, and Dr. Naveen for giving us the review in progress in India, future goals, publications, online education, AAPI contributions, and future vision. We are ready for the change. New frontiers in chronic pain, pediatric anesthesia, and cupped tubes, role of USG in emergency department, SGLT2 inhibitors, oral anticoagulants, and anesthesia implications, contactless monitoring, recent advances in neuroanesthesia, critical care in obstetric, and COVID, non-operating room anesthesia, and supraglottic devices for enriching knowledge in all above field. I thank Dr. Jyoti Pathania, Dr. Sukanya Mitra, Dr. Shamshed Begum, Dr. Rashmi Datta, Dr. S. Kumar, Dr. Anita, Dr. Manjunath, Dr. Manisha, Dr. Elja Rajan, Dr. Geeta, Dr. Ruxana, and Dr. Veersham. I thank all the participants for attending this program in large number. Dr. Manish, I thank all the technical team of Clarinet as a digital partner for providing support for this SEM. So thank you very much for you all, and see you next time for the same kind of the program. Thank you once again.